Great. I want to thank the organizers for inviting me. I think I'm the only endocrinologist on the panel. Maybe it's because I'm from Boston. Is that why I was invited? But I do appreciate this opportunity because I think this conversation, similar to what we've heard so far, is happening every day in the endocrine clinic, in the diabetes clinic specifically. I am the director of the diabetes program at Brigham and Women's Hospital. I have a hospital role, so overseeing how we manage diabetes on a hospital level, but also on a clinic level in specialty level diabetes care. So I changed the title of my slide from "Could SGLT2 inhibitors improve heart failure outcomes" to "Will," meaning that we know that they could. I think the data, as I'll present to you briefly, indicate that these drugs are potent, and they are through probably a multitude of mechanisms effective for our patients with heart failure. And if some of you attended Silvio Anzucci's talks during the sessions, I think he's part of the conversation as far as how that's panning out and why. So I think the answer is probably yes, but it depends on how we go forward in understanding the mechanism of action of these drugs. So I think I'll skip the outline just for interest of time, and I'd like to just surprise you instead. So let's go further. So we heard about heart failure and diabetes from Dr. Horwitz, which was beautifully done. This is a recent analysis coming out of the European cohort, heart failure cohort, that's been analyzed recently in a cohort looking at between 2011 and 2013. About 10,000 individuals with CHF followed, and similar to what we see nationally and internationally, about 30% of the cohort of heart failure patients had diabetes. And you can see here, it's a little bit blurry, but this is 1 year all-cause death, this is 1 year CVD death, and this is 1 year heart failure hospitalization amongst patients with diabetes here and without diabetes. And you can see there is clearly this diabetes disadvantage, which we've seen for decades across all sorts of cardiovascular diseases, not just heart failure. Unfortunately, in the clinic, with the exception of metformin and now GLP-1 agonists, perhaps depending on the stage of heart failure, and a few other very uncommonly used drugs, major drug classes have either known or proposed negative effects on cardiac outcomes. So we've been stuck in the clinic for years, really until just recently, as far as what is the optimal medication strategy for patients with heart failure. So in comes the SGLT2 inhibitors. These drugs take advantage of normal physiology. We all have SGLT2 and SGLT1 receptors in our tubules of our kidney. The job of these tubules is to hold on to as much fuel as possible, specifically glucose. So 90% of glucose plus up to 100% of glucose is absorbed by the SGLT2 receptor, which is a symporter. It also transports sodium, which is important when we start talking about heart failure. The drug class inhibits the SGLT2, allowing for glucose to pass through the tubules and be excreted. So going from the normal state of no glucose to excessive glucose in the urine. This is how it works for the patient with hyperglycemia. The effects are relatively impressive. It depends on your perspective. From a glucose lowering perspective, it's about average. It's not as good as metformin, which we use as foundational therapy. It's not a big splasher as far as that goes, although some trials have shown an A1C reduction by almost 1%. That's very rarely seen in longer trials. Weight change, there is a benefit. Patients do lose about 2 kilograms, and we see this in the clinic. There is a slight blood pressure reduction, but all of these are really relatively modest. And we've had these drugs in the clinic since 2013, so we have a little experience. I'm going to give you a case here, and I think this highlights some of the points that were made by Dr. Margulies as well. This is a 65-year-old man, a patient of mine, type 2 diabetes for 15 years. He presented to the Diabetes Center for usual follow-up after a year hiatus. He reported a progressive decrease in exercise tolerance that he described about 2 years ago in my note, but it was subtle, and his wife now says it's really been going on for about 5 years. He denied episodic chest tightness, pain, or other angina equivalents, denies difficulty breathing overnight, no signs of sleep apnea, sleeps with one pillow, but not a good sleeper, whatever that means. Physical exam, he's overweight. He has mild hypertension, although he's being managed, just not optimally. Clear lungs, probable S4, but no edema. He's on moderate intensity statin therapy, aspirin, and an ACE inhibitor. For his diabetes, he takes metformin. He takes insulin. He takes glipizide, which is a sulfonylurea, prior to meals. Now, both of those agents, glargine and glipizide, have been implicated in heart failure outcomes, just so you know, but they're effective in lowering his glucose. He does report that he has difficulty with this regimen, at least with the twice-daily medicine, so that's something we wanted to discuss. Laboratory evaluation, his A1C is not optimal. Goal for him would be less than 7. He has mild renal insufficiency, and his glucose post-meal is not well controlled. On cardiology evaluation, we'll get to that now, his EKG did indicate a prior inferior MI, as we see in a lot of our patients. On echo, his EF was 40% with no valvular disease. His stress was not significant, and his cath was unimpressive. And he's still he's working with cardiology. On return visit, I decided to change him to an SGLT2 inhibitor. I thought he might benefit not only from the once daily dosing, but also the glipizide I would like to reduce. Lantus was reduced as well. After a month, his GFR was stable, blood pressure improved, weight down 4 pounds, glucose levels mildly improved, but I had some room to go with the empagliflozin, so I increased it, and his insulin dose remained stable. Okay, this is a pretty standard case. We see this a lot. With this guy, this happened next. So he reports to me, he comes back, he says, "Doc, I went on vacation with my family. I can't believe what happened. I was running around with my grandchildren. I felt like a new person. I never felt better. I found myself running up the stairs, and my wife looked back at me and with her jaw dropped. And I just want to tell you, I think this drug is a miracle drug." Now, of course, a dramatic case, but it paints the picture, which is the question we ask ourselves: what did it for him, and what did it in the trials that I will present to you? First of all, we did start a new drug. His blood pressure improved, his weight improved, the glipizide was stopped, insulin was reduced, maybe that was relevant. And he also, of course, went to a beautiful place. I think he went to the British Virgin Islands, and maybe that cures some disease independently of anything else we do. So we don't really know what happened to him. Let's look at the evidence and think about our case as we do so. EMPA-REG was now completed a multi-center double-blind randomized placebo-controlled trial, as you no doubt have heard about. It was looking at the cardiovascular effects of empagliflozin as really dictated by the FDA in the United States to identify any negative outcomes of drugs coming down the pike. As you can see, it's 7,000 patients, a substantial trial. They all had, for the most part, they had cardiovascular disease. 75%, for example, had coronary artery disease. And they had diabetes for at least 10 years, so similar to our patient. A1C not well controlled, but not terribly controlled. They were most of them were on statins, aspirin, et cetera, and ACE inhibitor. They were randomized to placebo versus usual care, and I think that's important. We'll come up to that soon. The top line results are here. This is the big splash where we saw a 14% relative risk reduction in the composite outcome, which is the CV-related death, non-fatal MI, non-fatal stroke. But I think what was more impressive when they looked specifically at cardiovascular mortality, they were very surprised to see up to almost a 40% relative risk reduction, something we would see in statins post-MI, for example. And I think the size of this reduction was impressive, but also how early the Kaplan curves separated, which the company and not listed I think in the manuscript, but I think they separated out before 2 weeks. So whatever this was a very acute impact from this drug on patients with cardiovascular disease and diabetes. And if you look at hospitalization for heart failure, similarly, we saw a very early separation in the curve. And I think this ties in, but there was also incident worsening of nephropathy was also reduced, so sort of leading to the concept that probably renal disease and heart failure are connected in this patient population in this study. So in summary, we saw an improvement in heart failure hospitalization in all patients, but most of this data was not driven by patients who came into the trial with heart failure. This is important to note. Only a small percentage, so out of the 7,000, we just have 600 or 700. 10% of the individuals had heart failure coming in, and so therefore you don't see the hazard ratios being significant, mainly because the numbers are small. But keep in mind, this was really not a heart failure trial. Now, since the trial, the FDA has actually included Jardiance, which is the name brand for empagliflozin, to reduce, as an indication to reduce cardiovascular death. So it's changed our practice, but yet we still don't know exactly what we're doing. So let's just spend some time here on the plausible mechanisms for cardiovascular benefit. So what I can tell you, first of all, this is I think, a nice schemata from Tanaka, who's one of the trialists in Japan. And I think what he's indicating here is that there's probably some very early hemodynamic effect from the drug class, and then over time it might shift toward a beneficial metabolic effect, overall leading to cardiovascular and renal protection. Now, what these individual effects are, I think, remain to be seen, but I think he's right, that most likely glucose has nothing to do with this benefit. I would also probably argue that cardiovascular disease, which we know is linked to insulin resistance, et cetera, as we heard, is not related, coronary disease specifically, is also not related to the outcome. But yet it's probably pleiotropic. This is a little complicated here, but if we start over with energy, there's a potential shift in use of ketones in the bloodstream from this drug class. This is interesting to endocrinologists because it relates to an increase in glucagon from the drug class. But we don't know. That's a difficult path to go down, as was mentioned by Dr. Vest. Other impacts, I'll say, over here in the renal compartment, there's consideration of restoration of tubular-glomerular feedback, which improves in heart failure. It improves the communication centrally that sodium is being excreted rather than complete sodium avidity, therefore maybe altering the endocrinology of heart failure. And then, of course, the plasma volume reduction. What we don't know is where the hormones do come into play, and I think we need to see studies looking directly at RAS, the impact of RAS from the SGLT2 inhibitors, as well as glucagon, which could have vascular impacts. There's data supporting that. I'll skip that over. Yeah, okay. Keep in mind, one last point I'll make with this trial and others is that it's compared with usual care in the placebo arm, and if you look at the balance post-randomization of which agents were used in the care of patients with diabetes, we have an increase. More patients were placed on a sulfonylurea. More patients were placed on an insulin product post-baseline in the placebo arm, and more patients, surprisingly, were put on a TZD. These could have also altered the outcome, showing a negative effect, whereas the GLP-1 maybe is a small amount of patients. Okay. Just quickly, I think we don't have time for the safety, right? Yeah. Okay. All right. So I think that what I'm going to just finally say is that there are many trials. We have the Emperor reduced and the Emperor preserved trials that are ongoing. They're starting next week, actually, which will tell us about the impact on heart failure specifically in non-diabetes patients. And bottom line is, will these drugs make an impact? I think that it depends on our commitment to understanding why they work. We need more safety data. We also need to better understand the subclinical or undetected heart disease and diabetes. Thank you.